that we are in fact in new epidemics of police violence, mass incarceration, pipeline from school to prison, that we need new paradigms. We need to push on the paradigms to create more social change. And I'm very glad that we've gathered here together to do just that. So this panel, we're going to feature two wonderful speakers. Each of them will talk for about between 20 and 25 minutes. And I'm tasked with being the timekeeper, and we should have enough time for Q&A after that. So first we'll have Professor Bruce Link talk with us, and he is Distinguished Professor of Public Policy and Sociology at UC Riverside. He earned his MS and PhD degrees from Columbia University. His interests are centered on topics in psychiatric and social epidemiology. He's written on the connection between socioeconomic status and health, homelessness, violence, stigma, and discrimination. Currently, he's conducting research aimed at understanding health disparities by race, ethnicity, and socioeconomic status, the consequences of social stigma for people with mental illnesses, and the connection between mental illnesses and violent behaviors. I got a chance to look briefly at what he's going to present, and I know it's going to be a very exciting talk. So let's welcome Professor Link to the podium.
Terrific, thank you. It's great to be here. And it's in keeping with what Helena said about bringing people from different disciplines. I had the great pleasure of being the director of the Health and Society Scholars Program at Columbia when Seth and Helena were there. And some of this conversation for me began then. They became my teacher. I want to talk to you today about stigma as a fundamental cause. Some of you know that I've talked about socioeconomic status in those terms, but I want to talk to you today about stigma. And here's my goals. First, to propose stigma as a social determinant of health that stands with other such determinants like socioeconomic status, social relationships, stress, gender, and neighborhood conditions. And then to consider stigma, whether stigma is a particularly pernicious type of social cause that remains persistently associated with health inequalities across times and places through changing mechanisms. That's the fundamental cause idea. And then to talk a little bit about the potential value of a stigma as a fundamental cause lens for structural competence. Some of you know I've talked about SES as a fundamental cause, with the idea that socioeconomic status is related to multiple disease outcomes through multiple replaceable mechanisms. Mechanisms are replaced when people use resources, knowledge, money, power, and prestige and beneficial social connections, either individually for themselves or collectively, to gain a health advantage. And that they're flexible in the sense that as new things happen, new diseases arise, as new risk factors come into play, as new beneficial factors come into play, those flexible resources shape their distribution, reproducing associations between socioeconomic status and health across times and places. That's the basic idea of SES as a fundamental cause. Now I want to move to stigma. This is my other area. And so for 20 years, they were separate, the SES and the stigma. And now I'm trying to think about them together and to think about whether or not we can think about stigma as a fundamental cause. So first, what is stigma? So here you have Goffman, for those of you who've had exposure to him, who says that stigma is an attribute that's deeply discrediting and reduces the bearer from a whole and usual person to a tainted, discounted one. And then there's another definition by Jones, which is very similar. But if you look at those definitions for just a minute and see if there's anything you don't like about them, because some people who had stigmatized status didn't like aspects of them. One of the aspects they didn't like is that in those definitions, stigma was an attribute or a mark, something the stigmatized person has rather than something that's conferred or selected for social salience. So that was one thing they didn't like about it. The other is stigma research up till the time where we began thinking about what we would say it was, had been, the focus had been on the process of categorization, the linking of the categorization to stereotypes, and not to the broad discrimination that people felt like they were experiencing. So we decided to use those as foci to criticize the stigma concept and to say what we think. Now, this is not anything that's written in stone. We didn't climb a mountain and come down with it, but these are our ideas about what stigma is. Stigma exists when the following interrelated components converge. We took that idea from Goffman. Goffman said that stigma inhered in the relationship between things, and we expanded a bit the relationship of things that he said it inhered in, which was an attribute and a stereotype. So we say it includes 6 things. People distinguish and label human differences. That's the first part. And the idea here is that we're massively different on all sorts of ways. One of my favorite ways that I think we should differentiate people is whether or not they have hairy ears or not. It's genetically based. It's probably related to violence because men have it more than women. Well, we don't pluck that one out, but we do pluck out skin tone. So the plucking out is something that we achieve. Second, labeled persons are linked to undesirable characteristics, to unwarranted stereotypes. You've been in a psychiatric hospital, you must be dangerous. Labeled persons are viewed as us, as a them, separate and distinct from us. There's some separation. There's us and them in stigma. People experience emotional reactions to labeled people: fear, repulsion, disgust, and labeled people may feel shame, embarrassment, humiliation. So there's an emotional level to it. And then fifth, labeled persons experience status loss and discrimination. So they're put down and they're excluded and discriminated against. And if all 5 of those things cohere, we'll call it stigma. And then the final component is stigma is dependent on power, and I want to say a little bit more about that. So where is power in that definition of stigma? Why is it important to that definition of stigma? Well, it takes power to decide which characteristics to make salient. Somehow that definition is, that process occurs, and it takes power to who gets to pick out which ones. Second, power to construct ambient stereotypes. Who gets to make up the stereotypes? Somebody exercises power to make that happen. The power to broadly accomplish a separation of us and them takes power to do that. And finally, power to exclude from desirable jobs, housing, educational opportunities. Power is in stigma. Did I skip one? No. Okay, so is stigma a social determinant of health on a par with other social determinants? That's my first goal to try to convince you of. And if you go to something like the Handbook of Medical Sociology, where you might think that if it was a major social determinant, there would be a chapter about stigma as a social determinant. But there isn't one in there. There's ones on racism, social relationships, socioeconomic status, but stigma didn't make it in there. If you go to social epidemiology, the same thing is true. There's a textbook on social epidemiology by Berkman, Kawauchi, and Glimar. So why might it be that stigma's not in there? So I think it's partly stigma researchers' fault, my fault. So here goes why. So if you think about stigma, and you think about it broadly, on the left-hand side there, we have a whole bunch of things that are stigmatized. And that's the short list, right? Mental illness, sexual orientation, obesity, HIV/AIDS, disability, minority, race, ethnicity, and you could go on and on and on. So there's all sorts of things that are stigmatized. And so it's pretty common. Stigma is pretty common. It's not a rare thing. It's not just one of these things. It applies to a lot of them. And on the top there, you have all the different ways, things that stigma might affect: your housing, your income, your education, your social relationships, your self-esteem, and your health status. Well, what in the stigma field we often do is we pick one of those outcomes and we pick one of those stigmas, and then we study it. And going through, it's this one or that one. And what are we doing there? Well, let's pick one that we look at now. So minority status and race, ethnicity, with all sorts of things affect health status. Racism associated with minority status is one of those things. And if you go through any one of those X's I put up there, the stigma is just part of the effect on any one of those outcomes. They're influenced by all sorts of other things. But the idea is that you sum across all those things on the top and on the left-hand side, and imagine stigma affecting the whole. It's potentially huge, and it belongs as a social determinant of health. Now, But why and how might stigma be a fundamental cause of health inequalities? There needs to be some driver, something that says, hey, if I cannot create the inequality this way, well, by golly, I'll find another way. Something that's making this happen, animating this. I use by golly for missing the last person who ran for president for the Republicans. He used to talk like that. And then the roots of stigma often discussed as ignorance or bad information. We often think people just don't understand. But what I want to put forward is the idea that people have motivations in the enactment of stigma. They get stuff they want when they stigmatize. It's directed. It's on purpose, so almost. So here's motivations to stigmatize. This is why people might stigmatize, stuff they might get from it. And so one is exploitation or domination, which neatly summarized as keeping people down and exploiting them. Norm enforcement, keeping people in. And then disease avoidance, or keeping people away. Let me just elaborate each one of those slightly. So exploitation and domination are keeping people down. So racism and the stigmatization of African Americans to justify slavery for the benefit of white owners fits in the idea of keeping people down, using stigma to keep people down. The stigmatization of American Indians to facilitate the irrigation of their lands, domination benefits the white settlers that are getting the lands that used to belong to the Indians. Norm enforcement is signaled by perhaps the scarlet letter. Stigma is deployed to punish people who violate social norms and to serve as an example to all others that they should not do so. So stigma seeks to keep people in. So we can think to some degree the symptoms of mental illness try to keep people in, smoking, keep people in, people cutting in line, keeping people in. This is something else that stigma can be deployed to get something that all of us want, which is orderly social environment. But keeping people away, so stigma in this instance is used to keep people away, perhaps an evolutionary developed aversion to contagious disease, as indicated by skin lesions, but also erratic behavior, strange gait, and the like. So keeping people down, keeping people in, keeping people away. Now, they likely merge, but these are motivations that people might want to achieve using stigma. So my conjecture so far, people have motivations to stigmatize, to keep people down, in, or away. People achieve something they desire when stigma is enacted. If motivations are in place, we might expect stigmatizers to seek mechanisms, to go out and find them, to achieve their desired ends. Are there multiple mechanisms? Then the next question is, are there multiple mechanisms through which the desires of stigmatizers can be achieved? So that if one doesn't work, they can use another one. I think so. Here's 4 generic kinds of mechanisms. First, direct person-to-person discrimination. This is what we often think about when we think about discrimination. One person does something to the other. We have great audit studies in all sorts of areas, demonstrating that this happens for African Americans, for people with mental illnesses, and so forth. Then discrimination operating through the stigmatized person, the great example of stereotype threat, where all people have to do is be aware of the stereotypes that might be applied to them. If that's made salient in the context of testing, where African Americans think their ability is lower because of the stereotypes, it disrupts their performance and they don't do as well. And an important thing that selects people into higher status positions in our society. And then interactional discrimination. There's this theory in sociology, one of the only experimental parts of our field, that studies how in small groups, people who have external statuses tend to rise in a small group in terms of status, who gets talked to, who gets the floor most often, whose ideas are taken most seriously. And this all emerges even though the task they're given has nothing to do with the statuses. So men, higher educated people, dominate. And it just happens. You don't even see it happening. It just unfolds. So that's interactional discrimination. And then structural discrimination, policies that disadvantage stigmatized groups, or the absence of policies that might benefit them. So those are 4 generic mechanisms, but of course within any one of those 4 generic mechanisms, there can be all sorts of ways that we could do this. So if the desire to keep people down, in, or away is strong, The repertoire of opportunities to achieve such ends is extensive. There are multiple generic mechanisms, and there are also huge variation within each generic mechanism. There are all sorts of ways to make people feel uncomfortable and unwanted, all sorts of policies that can be enacted to disadvantage or signal that you are not a person of worth on par with others. What else would be needed to make stigma a fundamental cause? So we've got two things. We've got a motive, and we've got a flexible set of mechanisms. What else? Power differences. So in thinking about power here, I put up Max Weber and Pierre Bourdieu. A person's ability to exercise his or her will even against resistance from Weber, and then symbolic power as the capacity to impose the legitimate vision of the social world and of its divisions. So for me, in thinking about the stigma, the ability to decide which labels distinguish us, which stereotypes are prominent, and how strong they are. Who is us and who is them, and who has the capacity to impose status differences, and who controls access to jobs, housing, medical care, and other social goods. So the elements that might facilitate a fundamental cause relationship are present. Strong, enduring motivation to keep people down in a way, flexible, replaceable mechanisms to achieve desired ends, power differences that can be expressed in stigma components of labeling, stereotyping, separating status loss, and discrimination. But just to give you an idea, this is for those of you way in the back, you won't be able to see, but the idea here is that the motivations are in the ellipses, the arrows are mechanisms, and the three sort of columns are historical period 1, historical period 2, historical period 3. The idea is the mechanisms can change over time to produce exclusion, discrimination, segregation, stress, downward SES placement. So the things in the black categories. So just to go through something like our treatment of African Americans and racism in our society. If you're on the left-hand side, you can think of historical period 1 as being a period of slavery, where the main mechanism is just the institution of slavery, but if there's some freed folks, then the kinds of mechanisms are kept them down. We go to a second period, and the transformation of we no longer have slavery, but there's something very much like slavery in terms of indentured servitude and the like. And then Jim Crow laws would be the big arrow there in a second period. And then a third period, we get rid of the Jim Crow laws, the vestiges of servitude that mimic slavery are gone, but then we have mass incarceration, implicit biases and the like. The idea is that the mechanisms change, but the basic fundamental relationship is reproduced. And the question is, what that happens for African Americans, it has happened for African Americans in our society, can we think about that happening across a lot of stigmatized statuses? That's a conjecture. I think we can, for all the reasons I've said, but it's a conjecture. So then, just to say a couple things about how thinking about stigma as a fundamental cause is a little bit different than thinking about SES as a fundamental cause. So in SES, the use of flexible resources to gain a health advantage, something that you do for you or yours. You're out there advocating for your wife when she gets sick. You're buying into a wealthy neighborhood. We have great parks. The stores are well stocked and the like. For stigma, the desire is to keep others down in or away. It's something that you do to others to benefit yourself. And then when we start to think about stigma, we think about it as two-part fundamental relationship, fundamental cause relationship. So stigma is going to have a fundamental cause relationship with SES-related resources. That is, the stigma processes are going to disadvantage you with respect to education, occupation, social relationships, and the like. So, and those can be seen as part of what produce fundamental SES relationships. And then stigma has a fundamental cause relationship with health independent of SES-related resources. So I've got 1 minute, and in some ways, that's not such a bad place to start. Let me just flip through quickly. I said start, didn't I? Oh, man, Freud's around. Anyway, I will just stop right there. That's enough. I got across what I wanted to. Take care.
Thank you so much, Bruce. That was great in helping us keep on time. So now our next speaker that I'm really glad to introduce is James Quesada, who's professor and chair of anthropology at San Francisco State University. He earned his degree at my alma mater in the joint program at UCSF and UC Berkeley in medical anthropology. Jim's conducted research on a number of topics, including youth substance abuse and the health of migrant workers. One of his recent projects, called Study Youth in Northern California, was a training project to familiarize both public health practitioners, service providers, and youth themselves in the use of qualitative methods that can be used not only to describe afflicted communities, but also inform practitioners on effective means of addressing the needs and issues of affected youth communities. In other words, it sounds like they were doing a structural competency intervention. So let's welcome Jim.
All right, this is great. Thank you for having me. Let me just start right in, because I wrote this thinking I had like 30 to 35 minutes, and I've been hastily trying to prune this down, so I'm going to try and work within the time allotted here. So, it is clear as a society we have reached a point of acknowledging the importance of the social causalities and consequences of ill health, as well as the importance of addressing the social dimension of ill health and well-being. As a society, there's little doubt as to the high cost poor health, and the way we institutionally respond to it in the form of health insurance coverage or didactic doctor-patient relationships or disarticulated specialized medical services that are highly compartmentalized, etc. It is at a crisis point, especially in our inability to contain cost and provide greater effective comprehensive care. In the United States, approximately 50 million individuals, most of whom are low income and minority, are threatened by economic, cultural, environmental, and social conditions that contribute to or exacerbate poor health. Okay, so we know this. Whether we know this intuitionally, in general sense, or based upon sophisticated knowledge on how the social aspect of health and well-being are inextricably connected, such knowledge does not necessarily or automatically lend itself to clear, effective interventions that may require engagement with the lives of those presenting their health problems in ways that transcend the narrow practices health care is oftentimes delivered. Part of the reason why is that when the social dimension of health are taken into account, they are subject to a reductive gaze that sees the social in terms of the individual level risk factors, or a focus on health policy, on medical care, or changing individual behaviors. The most common way health interventions not only take account, but strive to address the underlying or proximal causalities of ill health, that is the social dimension of health and well-being, is to triage. Triage involves prioritizing the kind of treatment a patient requires based on the severity of their condition. This presumes an approach that not all the problems presented by a patient, whether as an individual or community, can be adequately tackled at the same time, and that choices must be made in selecting and ordering what should be immediately tackled, then what next, and next, in a fashion that ideally systematically addresses the needs of a patient. We accept this practice as common sense, a logical process, and outcome of delivering effective health care. A problem arises when the presenting problems of an individual or community are complicated complexes of overlapping, intertwining forces and factors, not only pathological, biologic, environmental, or psychological forces, but also social factors and forces that contribute to producing the ill health and presenting problems patients portray. There are patients, individuals, and communities whose presenting problems require multi-pronged interventions, more or less simultaneously, that will not benefit from a logical sequence series of interventions that are protracted over time. One of the virtues of public health interventions, as opposed to immediate medical clinical encounters that often address acute problems in need of highly specific therapeutic interventions, is a capacity to take account of the larger complexities of presenting problems and figure out interventions that strive to systematically address the complicated, entangled set of factors and forces that typify the health challenges modern society contends with. Yet even such knowledgeable understanding of the complexity of presenting problems that include the social context of causality and consequence, and the noble efforts to enact interventions that address these complexities are themselves contained and limited by a zero-sum rationing of healthcare services that reflects the concept of limited good. This concept of limited good from one of my professors, Dr. George Foster, asserted an ethos or a worldview typical of Latin American peasant societies that sees the world in finite terms, meaning that there is only so much resources to go around. I would argue that such a view is not applicable to Latin American peasant societies alone, but applicable to advanced capitalist societies as ours. In such a world of limited good, it stands to reason that health care delivery itself must be doled out, rationed, and logically doled out to meet a maximum good for all. In the United States, a history of discrimination and ineffective health care for cultural minority populations, from Native Americans in rural areas to African Americans and Latinos in segregated inner city neighborhoods to refugees from war-torn countries, spawned medical social science critiques of clinical assessments based on stereotypes around race, class, gender, sexuality, or citizenship that contributed to disparate clinical care and outcomes. In response to these challenges in the late 1970s, U.S. healthcare educators sought to promote cultural competency to ameliorate racial and ethnic disparities in health outcomes. Medical education incorporated the concept of cultural competency to sensitize healthcare practitioners and systems to the needs of diverse individuals and communities whose beliefs, values, and customary practices often differed from those of the health professionals serving them. Cultural competency, however, has been critiqued for inadvertently compounding cookie-cutter stereotyping of diverse patients. Furthermore, in practice, it has tended to focus primarily on cultural barriers to care framed in terms of race and ethnicity, often neglecting the negative health effects of political and economic and other social factors, especially socioeconomic status, the compound discrimination and barriers to achieving better health. An exclusive focus on culture misrecognizes the pathological effects of social inequality. This requires a shift from understanding the way culture plays a role in the inequities of the delivery of healthcare to an additional and fuller understanding of how social science, structural forces, and dynamics systematically impinge on individuals and communities. Drawing from an understanding of the nature and consequences of structural violence, public health and clinical attention to observing, understanding, and acting upon the ways policies, market forces, and institutional arrangements disproportionately shorten the lives of the poor provides an entree to engaging in interventions that can make a difference. Structural violence refers to how and why people live in worlds markedly different from one another, by how the accumulation of wealth in one part of the world entails the abject misery in another part of the world. As a sum, the idea of limited good plays out such that there exist in relation to each other within the same political and economic system structures that assist some and harm others, with structures referring to patterns of collective social action that appear to have a solidity and sense of permanency. a structure that is an observable regularity in human social activity, is visible not only in the form of concrete manifestations as buildings and the activities that occur inside them, vehicles and the pathways they follow, institutions like hospitals and universities in which specific practices are enacted, in which habits, social relations, economic arrangements, institutional practices, law, policy, and so forth take on qualities as concrete as buildings and institutions. Violence is associated to social structure when forms of suffering and injustice are deeply embedded in the ordinary, taken for granted patterns of the way the world is, such that structures that make life predictable, secure, comfortable, and pleasant for some of us mar the lives of others through poverty, insecurity, ill health, and violence. As such, social structures are neither natural nor neutral. They are the outcomes of long histories of political, economic, and social struggle, and are patterns of collective social action that can and should be changed. Many public health practitioners and medical clinicians are aware of the negative health effects of political and economic forces outside the clinic. Many, however, feel helpless in the face of these social structural forces and consider them to be beyond the purview of clinical practice. Others interpret non-adherence to treatment protocols and inability to pursue health lifestyle modifications to be the willful moral choice of the patients rather than the effects of social structural inequalities. As a result, public health practitioners and medical clinicians sometimes become frustrated by their patients or subject to burnout. Be that as it may, and in response to what we call structural competency, a tool we offer builds on critical social science work to help clinicians and health practitioners to address the effects of social inequality and global health disparities. To do this, we designed a clinical measurement tool to operationalize the concept of structural inequality. And here's a very brief definition of social structure, structural vulnerability, which is a tool that we've designed to try and get at the embodiment of all these injustices and how that becomes imprinted and reproduced onto the body and in relations with others. The social science concept of structural vulnerability to medicine takes the social determinant of health perspective as a foundation and builds on the wider range of critical social science of medicine and public health theory, highlighted by terms such as structural violence, racial disparities in health, eco-social models of health, upstream factors in health, fundamental social causes of health, social suffering, etc., to expand and define more practically the diversity of forces, both external and internal to the clinical encounter, that can sabotage the health of patients, regardless of the conscious intentions of the caregivers or the patient. Structural vulnerability is produced by one's location in a hierarchical social order that is embedded in diverse networks of power relationships and effects. An earlier conceptualization focused on challenges faced by Latino migrant laborers noted that marginalized and pariah populations are important examples of those affected by structural vulnerability, including the poor, the medically uninsured, the sexually stigmatized, the culturally subordinate ethnic minorities, the disabled, the formerly incarcerated, the drug addicted, the runaways, throwaways, people that have been disposed. In other words, the premise of a structural vulnerability approach requires ethnographic sensitivity to the specific set of challenges patients contend with physically and socially. And while awareness of structural vulnerability is not enough, healthcare practitioners facing time constraints and inadequate access to social service resources often feel overwhelmed by their patient load. We present an assessment protocol consisting of initial screening questions followed by qualitative assessment probes to help clinicians quickly gauge aspects of a patient's structural vulnerability. This tool is designed to guide priorities for immediate intervention and follow-up support strategies in order to move beyond simple recognition of problems. Our initial screening question, the domains represent let me find myself here, represents common social, structural, and institutional obstacles that can place a patient at risk for recurring negative health outcomes. As the patient homelessness in an inner city environment that is characterized by chronic open air drug sales and uses. And I think I just leaped ahead. Okay. I'm sorry. As I said, I was pruning this shortly before, so I'm sorry if it's a little bit disarticulated itself. In practice, clinicians will need to adapt the vulnerability assessment protocol to their patient populations, clinical institutional settings, and surrounding community resources. This qualitative version of the assessment tool is heuristic and represents an appropriate starting point and should be considered a draft for local adaptation. A secondary but important goal of our proposed clinical encounter tool is to improve the relationship of practitioners to the surrounding community by increasing awareness of the importance of identifying or developing community-based social service resources in response to patient needs. To illustrate use of our structural vulnerability assessment tool, let me draw upon a case of a structurally vulnerable patient I met in the streets, came to become more acquainted with at the Mission Neighborhood Resource Center, and who regularly used the ER of San Francisco General Hospital as his main clinic. MT is a 44-year-old Mexican undocumented day laborer with a history of hypertension, high cholesterol, and osteoarthritis. He presents to the emergency department with a broken nose and a black eye. He smells of alcohol and has a belligerent affect. The first person to see him after the triage nurse is a white female emergency medicine physician who has treated MT before for similar complaints related to physical trauma. MT is routinely admitted to the county hospital for acute inpatient care and then discharged back to the streets after several days, only to repeat the cycle of emergency department encounters and hospitalizations. Upon MT's release from the hospital, I wrote the following anthropological field note. MT comes to the day labor program with a bandage on his head and his face is swollen. He was discharged yesterday after 2 nights hospitalization with prescriptions for 1 milligram daily folic acid, 100 milligrams daily thiamine and vitamin B1. He holds up an unsigned prescription form with the medication naltrexone scrawled on it and asks me, shrugging inquisitively, they think all these medications are good for my alcoholism? He is too agitated to let me answer, telling me that last night he slept on a slab of cardboard in the alcove of a theater with an acquaintance. They were rousted in the middle of the night by a wild, crazy man. Early this morning, MT learned the man who shared his cardboard was found dead with his throat slit. He is scared the police are trying to find him for questioning and potential deportation. Another day laborer tells MT to shut up. MT shouts back angrily, but then runs away frightened. This field note highlights MT's immediate everyday survival emergencies that prevent him from engaging with the ambiguous and impractical follow-up care noted only semi-legibly on his prescription from the hospital. Healthcare staff may feel frustrated working with MT and other chronic utilizers of the emergency department, sometimes referred to derogatorily as frequent flyers, as they watch the health of these patients deteriorate between multiple cycles of urgent care visits. If average cost of an emergency department visit for an uninsured patient is $1,178, and the cost of one inpatient night in a California government-funded hospital is $2,590, MT's monthly average toll of 1 to 3 nights of hospitalization will cost well over $100,000 annually. Could such expenditures be allocated more effectively if the medical discharge treatment plans were to include housing and food vouchers, more appropriate and robust counseling and case management, along with substance abuse rehabilitation? In the short time at her disposal, MT's physician could pose our tool's initial screening questions during the social history intake to rapidly identify the salient parameters of his structural vulnerability that are most proximally propelling him to repeat cycles of homelessness, binge drinking, and violent encounters. In an ideal scenario, the physician might use the qualitative probes to gain a better understanding of MT's typical daily activities in one or more of the tool's 8 domains: his income generating strategies, his financial security, how and where he eats, food access, whether he has helpful or disruptive friends and family, social network, if law enforcement may be pursuing him, legal status and discrimination, where he sleeps and his perceptions of physical safety, residence, risk environment. By doing so, MT's physician might learn that MT has no formal education beyond 6th grade, has been undocumented in the United States for 15 years. She might discover MT has a girlfriend who is an alcoholic and generates income through sex work, with whom he moves between homelessness and temporary shelter. She might find out that he has an aunt in a nearby town who occasionally houses him and holds his mail, as well as one adult daughter who lives nearby, but has not spoken to him in 5 years. The physician might recognize that MT understands he has high blood pressure but cannot afford his medication copays. MT might admit he is a recurrent victim of street violence and that he binge drinks, is unable to escape chronic environmental exposure to alcohol and drugs in shelters and on the street, and is unable to manage outbursts of drunken behavior. I'm trying to cut here. The county hospital where MT was seen used to have a high user case management program in which an interdisciplinary team of health practitioners coordinated the care of structurally vulnerable patients. The high user team could have obtained MT a respite bed prior to his hospital release. They also could document how his problems are complicated by his legal status and refer him to an immigrant rights program. The time constraints faced by emergency department providers would likely oblige the physician to abbreviate her probing. She could, however, within a few minutes, screen MT as positive on the multiple domains of structural vulnerability, as well as document the more common social history, risk variables of alcohol, tobacco dependence, and intimate partner violence. Her intervention priorities for his problem list would need to balance MT's overlapping medical and social needs with available resources. Just one last thing regarding the potential for being able to engage in a structurally vulnerable or structurally competent intervention, and that is with respect to the high users program. The High Users Program began in 2001 to reduce hospital recidivism by addressing the biopsychosocial needs of high utilizer patients through an intensive case management model. Located in the county of San Francisco, only Safety Net Hospital and Level 1 Trauma Center, the High Users Program was designed to serve indigent patients hospitalized 3 times or more within the past year. In 2004, 2/3 of these patients were homeless or unstably housed, 70% had concomitant mental illness, and 80% had alcohol and substance use problems. The high user program was justified to administrators as reducing long-term costs by improving patient outcomes through streamlining the coordination of high-tech medical care and social service provision. Each patient was assigned an interdisciplinary team, social worker, public health nurse, psychiatrist, primary care physician, and clerk and case manager. They met twice weekly to formulate individualized treatment plans. The team's priority was to connect patients to safe housing, employment or public income subsidies, transportation, and community-based primary care, clinical, and social services. The high utilizer program's success demonstrated the ability of clinicians to engage productively with diverse institutional services outside the hospital to address structural vulnerability domains. The multidisciplinary clinical team proactively can be applied for public housing and communicate with the courts to contravene the contradiction between law enforcement and health priorities. The high utilizer program was often justified as cost savings as well as effective for structurally vulnerable patients. Yet administrative annual budget processes can overlook the benefits of these programs and eliminate them despite their delivery of high quality care. For example, the high user program was cut after 7 years during a dot-com bust in the San Francisco Bay Area. The program no longer exists at the county hospital where MT was hospitalized. Use of a structural vulnerability tool is no panacea, but can at least provide a means for more clearly defining the compound complex of presenting problems that contribute to ill health. It contributes to a more effective way to address these complications, but in the end, it signals drastic changes in the institutional practices of medicine and public health. Structural vulnerability is a heuristic instrument that can be used to justify the need for greater, more effective, innovative, cross-disciplinary, and cross-professional interactions. Thank you.
Thank you so much for that great talk. We do have time for Q&A, and we're going to invite our prior speaker, Professor Helena Hansen, up so that we can participate with all three of our speakers so far. So we do have about 20 minutes for your questions. So anyone having a question, can you please? Okay. And I think there's someone who's going to bring you a mic.
Sorry if I read off my phone. I've worked in various areas of the medical field, from first responder care to in hospital care. A common response when asking someone why they got into this field is because it's a well-paying job. Do you think that healthcare workers who got into the medical field as a way to make money and have higher social status, rather than their passion to help and heal others, has created a lack of patient advocates because they just want to move on to the next patient or finish their shift, is the forefront to inadequate patient care?
Should I take a stab? What a great question. So, on the one hand, what I've seen is that if we're thinking narrowly about medical school, those medical schools that have really opened up to social science and humanities majors and people who have worked in community health and different forms of health activism prior to medical school are getting classes that are already much further ahead in their thinking and their action along the lines of what we've been speaking. That's very clear. So I think you've put your finger on something really important. It matters who is practicing medicine, for sure. But on the other hand, I don't want to give up on those people who still make up the majority of clinical trainees, who go into medicine because their parents told them to. And they largely go directly from college, so they don't, and they come from affluent backgrounds. They don't have any clue what conditions are like outside of the neighborhoods that they've grown up in. So for them, I do think I've seen people who, as a result of spending time in patients' communities and really having personal connections to people working on the ground, begin to get much more of a consciousness And some of the people I can think of who are my colleagues who have been big advocates for this approach started off that way. So I think the more that we can make it, like my fixation is how can we bring this into the mainstream, because health activism has always been there and I hope it will always be there. Is there a way that we can push the center of medicine a little further towards where we work? And that's going to require winning over just the people that you work with, that you describe. Making it part of the air that we breathe, you know?
I just wanted to say something about that. I think that we also have to look at institutional and structural factors in education. Even though I'm not a physician, I actually teach them in the School of Public Health, and I've had them say to me things like, I learned racism in medical school. I learned to be insensitive to patients, to people in medical school. So I think those structural and institutional factors that people have been talking about are very important, as well as who comes into the setting. Thank you. Is there another question? Nancy?
I guess I'll maybe address the last two, Bruce and Jim. And, we've been struggling in the Rad Med to come up with a roster of questions that might be added to a clinical encounter. And I'd like some of the people here that work in emergency rooms or whatever to refer to how possible or impossible it is, and the factor that you're talking here with MT, with the poor within the poor, as Brazilians say. I mean, it's really... and these questions are highly stigmatizing and perhaps belong more in the hands of, I know you're talking about a team that includes, probably social workers, maybe clinical psychiatrists or whatever. But this is this question again of medical humility. What is it that these could interfere with those questions? We had questions like, are you in debt? Have you ever been involved in a violent altercation or whatever? Obviously, these are things that are important context, but I'm not sure that it doesn't violate some of the role of the physician in terms of empathic hearing just by seeing. That is, you kind of could answer some of these questions by looking at the person and their charts to know what the situation is. So I guess it's, again, how to operationalize what we know about structural matters. And I guess the other thing is there's no question here about working politically within the community, within the state, with the mayor's office, with churches, whatever, rather than just a bunch of experts who are working on the person. That, it means a broader reach, and the doctor can't do everything. I guess that would be my comment.
No, I absolutely agree with you, and I do think there are severe limitations. At the same time, I'm thinking of those points of entree and trying to be able to get a clear idea of the social context and the backgrounds of the very people that are presenting the difficulties that they have. Trying to find a heuristic device to be able to do that is problematic, and I would actually say that it's not merely about, I've been loath to put this on paper as if this can be just sent out and just taught. What has to be part of this is training in ethnographic sensitivity, being actually sensitive, talk about humility, being humble in how that is applied. Can you talk into the microphone? Okay. So there's that part. I think the other part that I think is really important is that in using this, it's, this talk ought to be actually be given to mayors, to the board of supervisors, to people in power, to recognize the fact that what needs to be mobilized aren't just internal health resources, but how it interfaces with numerous social resources that need to be mobilized to care for the very people that they're coming that they're encountering. But I do want to acknowledge the fact, yes, there is the problem of possibly reproducing the same kind of stigmatizing that oftentimes happens inadvertently. At the same time, you know, I think it's an effort to try and be able to get at the social context of what is going on, and also it means about being able to get clinicians to be able to understand that they have a role in interfacing with other services as well.
I guess I was just interested in the back and forth there, and it led me to think something I hadn't really thought before, which was how fraught this interaction could be with communicating things you don't want to. On the other hand, so I hope people will get the skills, because I think on the other side, when you do have the stigmatizing circumstance and it is felt, it's super important to have it understood.
Can I add one thing to that? Which was just looking at Bruce. I'm reminded of the power of peer and community health workers. And again, it could matter a lot who does the questioning. So the brilliance of structural vulnerability checklist is it plugs into the way that clinicians are already operating and trained. So we're introducing something foreign, but with a recognizable format. So it's much easier for them to adopt. Now that we're in the era of multidisciplinary teams and some openness to reimbursing community health workers and peer workers, people in psychiatry with lived experience, I know Bruce has done a lot of work with them, that could also influence how we ask and who asks. And I think that will have a lot to do with the possible stigmatization, which is a great point.
Great. I understand we have 2 questions from the back.
In terms of burnout, half the doctors are burnt out at this point. What are we doing about that?
Could you restate your question?
In terms of burnout, half the doctors are burnt out, qualify for burnout. What are you doing about that?
Doctor burnout. What's happening with doctor burnout?
So again, I'm kind of uneasy that so much of our discussion is about doctors. Even though I'm a doctor, I feel so we have to broaden the discussion. However, I'll say as a doctor that it is incredibly rejuvenating to work on structural levels and to work in communities. And I think one reason why so many doctors are dropping out of practice is that they don't practice that way. So I'm suggesting that what we're advocating for is a form of medicine that will counteract burnout. Because if you have a sense of empowerment that you can work at the levels that matter, you're much less likely to burn out.
I would just add to that I think a good reason why there is a lot of physician burnout is because they don't have allies. I mean, in terms of forceful and actual strong relationships that work with one another. I think the accent on multidisciplinary teams, I think, is really important. And you have there, interwoven allies and cross relationships that can really help mitigate some of the burnout that many, not just physicians, but all frontline service providers have to contend with.
Thank you. We had another question.
My name is Milana. I'm a family medicine resident at UCSF, San Francisco General. And I don't have a validated tool for detecting structural vulnerability, but I don't feel that I need one because the structural vulnerability that I'm able to identify far exceeds the resources that I have to address those issues. I think what I'm much more curious about is actually how to engage leadership and stakeholders in medical systems in actually directing funds and resources towards addressing structural vulnerability. So how can we do that?
Oh boy. Yeah, I mean, this is part of the problem with we can become very sensitive to the status of structural vulnerability of the people that we encounter. So what do you do with that knowledge? particularly if the problems are so immense and requires the mobilization of resources that are so hard to do. So in many ways, what this signals, and being able to document just the extent of how much the people that we encounter are structurally vulnerable, is to be able to document the absolute need for these vital services. You know, again, we could get a clear diagnosis. The question is what to do with that. And I think that's the, you know, $100,000 question right there.
Did you want to say something? I just wanted to add that this is the key question, right? And actually, we are not going to be given this, you know. We actually have to organize and force healthcare institutions and funders and other institutions to work this way. So the question is, how do we prepare ourselves to organize and do that work of forcing them to allocate resources? What I'm seeing in New York is actually the student organizations are having a big impact. They're bringing negative publicity to campuses where they're not getting a response, positive publicity where they are getting a response. The students are actually being listened to, and they're getting resources redirected. Like, there's a huge dichotomy between faculty practices and Medicaid practices at most of the medical schools in New York City. And the students are the ones that have gotten attention to that and gotten more resources for the Medicaid and started to break down the Jim Crow nature of that healthcare. Then looking from the perspective of faculty, again, it matters who's on faculty. If we can get more people with training in social determinants and structural determinants on faculty, then we'll be able more easily to pressure the institution. So I want to encourage all of you here to remain active with clinical education, even if you're not a clinician. We need you.
Other questions? Yes, right up front here.
Thank you, panelists. So my question is within regards to addressing the structural aggressors or the actors of the aggressors. What would be the intervening response? Or what would that look like to you?
Well, I think he's asking us, what do we do to the people do you know Nancy Krieger's thing, the spider in the web? Who's making this happen, and how do we respond to them, you're saying? I mean, the way I think about stigma, there's two things. You have to change the way people think about, or you have to change power differences. And I'd say that if you have a social movement going, like if you the gay rights movement, and you think about how power has come to be deployed in instances where governments have taken up anti-gay legislation, like in North Carolina, you've seen a switch where now you have sports teams, Google, businesses exerting power. I mean, now how do you get to that point? It's a lot of work, it's slow, but it can happen. So I think a lot about the social movement aspect, which is part of what's so exciting about it, to be here today. You know, that there's some spark going on. And
Other questions?
Hi. So a major issue that I don't think anybody has addressed is the lack of funding that all these programs require. For your the list of questions, you would need additional staff for that. The problem with that, I think, leads back all the way to the government, because based on my research, I believe 27 or 23% of our yearly budget is spent on administrative costs only, compared to 13 or 14% in other countries. What can we do to resolve those issues?
Yeah, I don't know. These things can be readily addressed in the short term. But I think what's really important is that a good deal of what we're talking about is trying to construct a genuine social medicine. I mean, we have to be thinking of different models of how we deliver health care. And so that doesn't answer your question in terms of the immediate issues of funding and what have you, but it really does mean, and I think what a large part of what we're doing here is challenging the institutional nature of how healthcare is delivered, and we really need to be rethinking how medicine ought to be considered, not considered, should be a practice of social medicine. And then perhaps priorities in terms of funding can be made accordingly.
I think that was very well stated, and the question captures the importance of political action on city, state, federal levels, because the overhead that you're talking about that the U.S. has that other peer countries don't have has to do with our managed care, privatized system. That money is going into the pockets of administrators. So for instance, if we were going to go for a universal health system, which is what our peers have, then we have to organize at all these levels, particularly the federal level. So we shouldn't be scared to do that. That's what it takes to practice social medicine.
There's another question over here.
My question is around the relationship between stigma and segregation. One thing I'm aware of in the psychological literature is in combating stigma, what we know to be maybe not sufficient but certainly necessary is contact between two groups, so that the idea of the stereotype begins to break down. In Berkeley right now, that everything seems possible. At the same time, I'm aware of the political picture at large and the country feeling more polarized, certainly than I can ever remember it, and essentially resegregation of our schools. And so I'm curious around, from either the micro level or the macro policy advocacy level, strategies to combat segregation given its likely reciprocal relationship with stigma and the reinforcement of structural violence.
Well, that's a super good question, and I don't have an answer for make it go away. I mean, I think it's a struggle, and I think that policies created what we have, and policies can be altered to change it. I think we have to recognize the history of it, and that it was created. It doesn't have just today, but because of redlining a long time ago, and then it's reproduced and so on. I think that we have to be attentive to the policies that recreate it, and we're implementing those policies now a lot on socioeconomic grounds, and our socioeconomic segregation is increasing substantially, and that there are policies that make that happen. And those, I would say, the prime thing for me I would think of is to combat those policies that are pushing it. I'll just say one other thing. There's that really interesting story about the science paper where they did because you said at the psychological level, where they did the canvassing, people who came and said they were gay, lesbian, and they wanted to have tell the people about gay marriage rights. And then, it showed this huge effect, and then it turned out that the data had been made up, but then they came back and redid the study, and somebody did it and actually did the study, and it showed the same results, and that's kind of hopeful. Not that the study came, but that kind of contact can matter. So.
Great. Thank you, Bruce. We have two more questions, this gentleman and then this one.
Richard Garcia, do you have a question?
I think that if you give a doctor this and they start asking all these questions and the people start saying yes to a lot of this stuff, and the waiting room is full, there's no way any of this is going to happen. Not to mention, there's nowhere to go even when you do find out that there are some problems. And so the way doctors get paid is completely unrelated to any of this. And so the intended audience for this kind of session really has to do with how doctors get paid, how hospitals get paid, where the money comes from. I was talking to my buddy who has a mobile asthma unit in East LA when I was driving up here yesterday, and he talked about how the ROI on that is tremendous, and the patients are doing much better in this unit, and they're about to close it down because the people who fund this don't understand what is going on. Okay, so right now there's a payment reform that is forthcoming that will look at health outcomes. These can be defined all sorts of ways, but we all know that the health outcomes in Marin County are better than the ones in Oakland. And so the payment, however you discuss that, this is a perverse positive feedback loop. And so the people with better outcomes are going to get more money, who then will have better outcomes. The people with worse outcomes are going to have less money and going to have worse outcomes. This is going on right now. And so that's the intended audience. We all understand all this and agree. I won't tell you what I do for a living.
Did you want to talk about it? I'm pointing to Bruce because he's the one that clued me into the inverse care law, right? Hart in the 60s in the UK. And it really was just that, you know, the worse off get the least investment. So it's totally, and this comes back to why a market-driven system is bound to fail. Even though in the short run there's certain instances where you can make a pitch for the cost efficacy of social intervention. And there are lots of examples that cropping up of that now. In the end, though, the bottom line is still not the patient outcome. It's the cost. So in a market-driven system, there's going to be a lot of cases where the inverse care law comes into place. So, and I do know where Richard works, and it's really hopeful that he works there because he's a real brother in this struggle.
Okay, I have a couple questions that are partially fake questions. So it's okay if you have multiple identities. How many physicians or medical students are in the audience? Raise your hand. How many nurses are in the audience? How many public health people are in the audience? How many how many social welfare or social work people are in the audience? How many urban planners are in the audience? How many social scientists are in the audience? How many community organizers are in the audience? How many activists are in the audience? Okay. I'm just reminding us all that we keep talking about physicians, but that's not all we're talking about. All of us in our different professions and disciplines are really important in this, and in our non-professions and non-disciplines. And
all are being called to be physicians, right?
Right.
I mean, that might be one way of thinking of it. Everyone in this room is going to need to be a physician.
Or to prevent problems before they even happen, which
Preventive physician, preventive medicine physician.
Which is the public health mandate.
The other fake question I had is that in the structural vulnerability assessment tool, given this panel, Helena's talk, Denise's work, Bruce talking about stigma, the last one of discrimination I think is really interesting. It asks the clinician or the public health provider or the social worker who has a lot of training in this and has a lot of work to do, to ask the patient or the neighborhood or the city, have you experienced discrimination? But it also asks that professional person to ask themselves, might some service providers, including me, discriminate against this patient for some reason? And that's really important to breed that reflexivity that then allows us to question the frameworks through which we see people and try to work towards these big changes in reimbursement, Richard Garcia, in how our system works in market-based healthcare. That's all I have to say. Those were my fake questions.
I think our session is over. Thank you so much.
Thank you, Denise.